Thank you so much for that nice introduction, and thank you all for coming. So I'll be talking about this very interesting topic that affects us all. So no disclosures. So the goals will be to provide a practical review of chest CTs, understand nodule prevalence and etiologies, talk about the guideline recommendations for follow-up, talk about the different characters of nodules, some cases, and then some important lung cancer screening details. So just a very quick background about CTs, because it just never ceases to amaze me how amazing this technology is. So it was invented in the 70s by Hounsfield, who we still use his name in regards to the densities. A single slice, and this was his brain, took hours to get. Now we can do an entire body within 10 seconds. The CT technology has drastically changed, particularly in the 2000s. This is an old number. It's probably at least double at this point. So 100 million cases a year. And of that, 10% generally is a chest CT. When we look at CTs, what you're looking at is the density of the body, as opposed to like MRI, which you're looking at water content and other things. So everything is a density. So the least dense thing in the body is going to be air, with like a minus 1,000 Hounsfield units. Then you have fat, subcutaneous fat here, which is about minus 100. Then you have water, which I don't have a picture of here, but that's 0 to 20. So you see that in like the gallbladder or in the kidneys. Soft tissue is in the 50s, like the muscle here. Blood tends to be in the 40s, and calcium is some of the highest Hounsfield units in the body outside of metal or contrast. Costs about approximately $500 for the case, to do a case, and then you guys are all familiar with the general indications. In just a general CT principle, as you know, chest CT is way more sensitive for all pathology compared to X-ray. I would strongly advise that even with a negative X-ray, you should consider a CT. Lung cancer and metastatic workup, as you know, should not stop with a chest X-ray. You have to continue with chest CTs. And then there are certain cases of individuals who we routinely monitor every 6 to 12 months. So people with lung cancer already, they get 6-month scans, because not only to look for recurrence, but looking for new lung cancers, which happen at an average rate of about 7% per year. And then other known cancers that we deal with all the time, like liver cell, renal cell, head and neck, they're going to be scanned every 6 months. When we talking about this, we're obviously something that needs to be discussed is radiation, especially when we're talking about following up on nodules at 3 months, at 6 months, a year. So this is one of the issues with radiation is the units. The best unit to understand is the millisievert, which is the amount of radiation that actually gets absorbed by the body. And we all are exposed to about 3 millisieverts per year. Most of that comes from radon in the ground, but you can see other things in the sky. Other etiologies can also give us radiation dose. So what does that mean in regards to imaging? So this is also an outdated slide. There is not great new material on this, but generally, a chest CT, I would say, depending on the place, is going to be from 2 to 5 millisieverts this time. Lung cancer screening CTs are less than 1 millisieverts, and an X-ray is generally less than 0.1. So it takes about 100 X-rays to get to a CT. And you can see also that, that this number is actually quite low compared to what average abdominal CTs do, which is routinely about double. And the reason is the chest doesn't have generally that much fat to penetrate. And so it can be done at lower doses. Bellies need a lot more radiation because of the increased fat. And a principle that we use in radiology is called the ALARA principle, which is as low as reasonably possible, essentially. So our goal is to produce an image using the lowest radiation that is still diagnostic. And we're very good at that at Sinai. We take a lot of pride in how low dose we can do it. And then just to show you, this is at every scan, you'll have this information, which is a dose report for the patient. And again, these units are very bad, but essentially what we do is we take the total DLP, which is called the dose length product, and you multiply it by a specific K factor that for the chest is 0.014. And you multiply the DLP by that, and that gives you the millisieverts. So one chest CT in this case is almost approximately 1 year of radiation. And obviously the risk with radiation is potentially, cancer development, and the jury is out. There are some people who believe that these CAT scans are going to create lots of cancers in the future. That data is really based on Hiroshima and Nagasaki and other disasters like Chernobyl, which is much different than what we're doing. But still, it's something to be super conscious about and just be wary of it. Okay, so in general, most CAT scans can be done without IV contrast. So for lung cancer, nodules, pneumonia, rule out Mets, all of these things, C-, no contrast. Contrast studies are absolutely necessary for pulmonary emboli, dissections, hyaluradenopathy. It's very helpful because there's a lot of action in the central lung nodules for that same reason, so we can tease out what's the artery, what's the vein. Abscesses, AVMs, pleural effusions. With and without is almost never indicated. More is not always better, and almost all information can be obtained from the contrast enhanced portion. And just to show you that here, so this is the C-, this is the C+, here's the aortic arch, here's the innominate vein, this is a lymph node. So it's a lymph node with or without contrast. It doesn't change much. The definition is slightly better, but we're quite used to what a non-contrast looks like, so we know what we're looking at. But interestingly, if you see at the bottom here, you can see there's a much big difference between this and this. So you have this paraspinal density here that once you give contrast, you can see that it's actually rim enhancing, and this is a paravertebral abscess, which we could kind of potentially elucidate from the non-con, but certainly helps with the contrast. All right, so one useful use of non-con with and without is in an aortic dissection, and the reason is that if you look at this image, which is a contrast study, you see this low density in the descending aorta, which could be non-calcified plaque, but in this case, it's intramural hematoma, which tends to be bright on the non-con and can be obscured with the contrast. So dissections involve non-cons and cons to identify this intramural hematoma. Nowadays, with a general CT, they're all high resolution. We do everything high resolution here, which just means thin cuts. 1 millimeter cuts is the routine these days. Inspiratory and expiratory CTs are very useful in when we're looking for air trapping in patients with lung transplants to look for bronchiolitis obliterans, tracheomalacia. All right, this is an example of an inspiratory and expiratory slice through the trachea. In inspiration and expiration, you can see there's loss of the AP diameter and this frowny face, which is indicative of tracheomalacia. So then the super low dose chest CT is the lung cancer protocol, which generally is sub-sievert. It's used pretty much exclusively in lung cancer, but it can be used in a lot of different indications, but we like it for lung cancer. And you can see here that this nodule is quite easily seen. Again, the chest is not that much soft tissue to penetrate, and the lungs are very forgiving from radiation. But you can see here that if you were to look at the soft tissues, you can see how noisy they are. And if you go to the abdomen, you would see just how noisy that is. And it becomes almost unreadable. But the lungs are very readable. Okay, so then just quickly some more chest CT descriptions before we get into the nodule stuff. So ground glass is defined as hazy densities in the lung parenchyma that you can still see through. You can still see vessels. And it has one of the most wide differentials in all of CT. So it could be infectious like PJP. It can be inflammatory like ARDS. It can look like hemorrhage here in this patient with diffuse airspace ground glass with peripheral sparing. Consolidations are more dense, so you can't see through the lung. You just see the consolidation. You can't see any lung architecture. You do see air bronchograms, which is a good feature of consolidations, which are typically pneumonia, but they obviously have their own differential, which can include malignancies like adenocarcinomas or lymphomas. This is septal thickening in the lungs, which in this case, this is smooth septal thickening, which would indicate interstitial edema or fluid overload. With fibronodular septal thickening is more indicative of malignancy like lymphangitic spread of disease. And honeycombing, which is routinely described in pulmonary fibrosis or UIP, usual interstitial pneumonia. Honeycombing are these stacked cysts in the subpleural lung. It does get difficult to distinguish what's bronchiectasis and honeycombing in these cases. Basically, what you would do is connect the bronchi by going up and down the image, and if they connect, then it's bronchiectasis. If they don't, it's honeycombing. Okay, so then just a really quick case here, just to understand the utility of chest CT. So this is a patient who's intubated. They have diffuse disease, diffuse aerospace opacities. The CT is really just going to show the exact same thing, which is diffuse aerospace opacities, and the differential remains completely the same. Infectious, inflammatory, ARDS, edema. The only clue from the chest CT might be that this is a young patient with a lot of coronary artery calcifications, but honestly, that doesn't mean much. Differential, which is quite large. Really, the only way to know is clinically, and time is usually one of the best tellers. So, very typically in these settings, right, the intensivist will throw a lot of things at the patient, Lasix, steroids, antibiotics. But really, the only thing that could clear this dramatically would be edema. Everything else is gonna leave some residue at some point. And then further on in this patient, after a Lasix, they were able to breathe better, but we can see in this cardiac MRI that the septal and anterior walls of the heart are not moving. And this was an LAD infarct with a severe systolic dysfunction. Just a couple more descriptors. Here is central lobular emphysema, which are these lucencies in the central lung with some distortion of the parenchyma. Paraseptal emphysema is air-filled cysts in the peripheral part of the lung. Panlobular is when the emphysema is at the bases of the worst, which is unique to things like alpha-A1 antitrypsin deficiency. Bullae are these large air-filled cystic spaces that tend to occur in the lung apices and can lead the patient to get a pneumothorax. And then this is the mosaic attenuation. So in inspiration, you can see that there is this sort of geographic heterogeneity of the lung parenchyma. Here you can see there's this region of lucency next to these areas of ground glass, lucency, ground glass. When they expire, this is more dramatized. So you can see the geographic heterogeneity better. And this is a whole lecture in itself to understand what's happening here. But what's happening is when the patient is expiring with their breath, the lung parenchyma is going to get more dense because air is being released. So the normal part of the lung here is the ground glass. The abnormal part of the lung is the lucency. And that part of the lung is unable to compress because the air is being trapped. Okay, so now on to lung nodules. So a lung nodule is defined as any lung opacity that's less than 3 centimeters that has a round shape. It's infrequently detected on X-ray and very commonly misinterpreted on X-ray as vessels or things of that nature. It's unbelievably common in CAT scans of the chest, which we'll discuss. Almost every nodule that we see is found incidentally. And they're way more common as we get older. And so I would say, we're going to go over these prevalences later in different populations, but it's almost impossible. If you're older than 50, the chance of having at least one nodule, in my opinion, is probably greater than 75%. That's just how common this stuff is. It's uncommon at young ages. It's uncommon in young patients. This was told to me by Lou DiPaolo, who is one of our pulmonologists, who said that when a patient hears that they have a lung nodule, it's an emotional tsunami, meaning they are very scared. They don't know what to do. They can go to Google and see what it says, and it gets to be very scary. And it's very difficult to impart the sense of how common this is. And that's really one of the jobs as a clinician, as a radiologist, is to inform the patient that this is actually quite common. Nodule follow-up is by far the most common indication for a follow-up radiologic exam. And that's, again, because almost every single person will have a nodule. Other routine follow-ups in the body are honestly not that common. Renal cysts can be followed if they're slightly more dense than normal. Sometimes we follow pancreatic cystic lesions, but in general, it is what it is, and you don't look at it over time. For incidental lung nodules, follow-up is guided by the Fleischner Society, and those recommendations differ depending on the nodule type. For nodules detected by lung cancer CT screening, it's not incidental, right? It's what you're looking for, and those are reported with lung rads. You actually don't need to use lung rads. And at Mount Sinai here, we have the IL-CAP group, the early lung cancer action program group, and they don't use lung rads. They form their own system, which is almost identical to lung rads, except it's not explicitly said what the grade would be for the individual. So there's a gigantic differential. Almost everything in the lung that's not a cancer is going to be a granuloma. Whether it's calcified or non-calcified, it's almost always a granuloma. And that can exist for so many different reasons. Anything you could inhale can form a granuloma. Obviously, any tuberculosis or mycobacteria type organism that can get in you, fungal infections, everything can cause a granuloma. Neoplasms, we can differentiate based on their morphology. So primary lung cancers tend to have irregular or spiculated margins, whereas metastatic nodules tend to be smooth. Carcinoids tend to be smooth. Hamartomas, which is the most common benign nodule in the lung, tends to be heterogeneous with different attenuation in the nodule itself, hopefully calcium or fat, which allows us to identify it. So then again, infectious nodules can be from granulomatous or fungal disease, abscesses, septic emboli, viruses, inflammatory nodules, and sarcoidosis, rheumatoid nodules, the necrobiotic nodules, and in theory, pulmonary AVMs. Now, something that you might have heard about is the MIP images, the maximum intensity projection images. So we do this on every case, and it's essentially what it's doing is it's taking 10 millimeters worth of data and superimpose it onto one image. And what it allows you to do is, at any given instance on this picture, right, this is a nodule, that's a nodule, that's a nodule, that's a nodule, right? But we know it's not because when we scroll back and forth, we see it connect to the vessels. The MIP connects the vessels for you because, again, it's taking 10 millimeters of data and putting it together. So what happens is it becomes a lot easier to see the things that don't connect to the tree. So finding a 2 millimeter nodule is a lot easier than it used to be. And we'll discuss how important that is, but you can see almost everything with these MIPs. Okay, so moving into the nodule characteristics, which are probably one of the more, outside of size, is going to be the most important feature that's going to distinguish malignancy from non-malignancy. So spiculated are these irregular tags coming from the nodule itself, and this is from a fibrotic reaction in the pulmonary interstitium from the tumor. Another important factor is going to be the growth rate. This is very important, actually. So in this case, let's just look at this one. The rest were not cancer. Here, this one, which growing to this size in a year is about the sweet spot that we look for in lung cancer. The nodule density, so when we see a ground glass nodule, we call it non-solid. We're going to go over this stuff. And when it has a solid component, we call it a part solid nodule. So we would measure the whole thing, and then the solid component would be measured separately. Calcifications in the lung nodule are almost always a sign of benignity. And these are the benign features of calcification, which is either a diffusely calcified nodule, a centrally calcified nodule like a bullseye. These popcorn or heterogeneous calcifications are also commonly described in hamartomas or granulomas. And then the location, and this I find is very important because lung cancer loves the upper lobes, particularly the right upper lobe. So and the lower lobes just in general get a lot more junk. So meaning they get more infections, they get more atelectasis, they get more of everything. The upper lobes generally don't get that junky, but they do love cancer. So to me, I take seriously the lung nodules in the upper lobes a lot more serious than the ones in the lower lobes. Metastases, because their blood usually hematologic spread, because the lower lobes get the bulk of or get more blood flow than the upper lobes, the predilection is for metastases to go to the lower lobes. So this is just a quick review of pulmonary metastases. So this is a very dramatic example of these so-called cannonball metastases. They have very smooth borders. They're innumerable in this case, and this is what METs typically look like. Almost all of them almost always look like this. Bladder cancer is one of the weirder ones that tends to cavitate and look very different than most typical METs. So the most common primaries to metastasize to the lung are essentially the most common cancers that we know: breast cancer, colorectal, renal cell, head and neck. And then there are other less frequent primary malignancies that have a predilection for the lungs: melanomas, Ewing sarcomas, and thyroid carcinomas. And the lung is by far the most common place to get metastases in the body. When we talk about the size of a nodule, we have to understand sort of what it means in regards to the malignancy risk. So you can see here that less than 6 millimeter nodules have a less than 1% chance of malignancy. And that's a very good number to remember. Just as the bulk of nodules that we find are going to be less than 6 millimeters, and the malignancy rate is so minimal at such a small size. As you get larger, they get significantly more likely to be cancer. So especially once they get to be 2 centimeters, these are almost always cancer. The malignancy risk goes up when you have emphysema or fibrosis, probably from the chronic inflammation that the lung endures with those states, and that causes more malignancy. The doubling time, which I kind of referred to before, is an important feature. Benign things generally grow super slow or super fast, right? So infections grow fast. Benign nodules like hamartomas, it takes forever to grow. But malignant nodules have this sweet spot where they double in about 100 days, and that's very indicative of a primary lung cancer. And, besides what we see and what we say, there are these calculators on the internet which allows you to sort of give a better percentage of what this could be. And you can see here that the most important ones from this Mayo Clinic one are the age, whether or not they're a smoker, do they have any other cancer, the size, the shape, where it is in the lung. And with all of that stuff, you can spit out a number of the chances that this is malignant. Okay, getting into Fleischner guidelines. There are a couple of really important things to understand about Fleischner. One is who it applies to. So it applies to newly detected or a detected nodule in a person who's 35 years of older, and it's incidentally found. So meaning if you have breast cancer looking for Mets and you see a nodule, it's not incidental. It's what you're looking for, and those play by different rules. Same thing with head and neck cancer, any cancer, right? But we're talking about a patient who's, let's say, coming in for shortness of breath, for interstitial lung disease assessment, for rule out PE, those sort of etiologies, and you find a nodule. Or you get a belly CT looking, if somebody has abdominal pain and they find nodules at the lung bases, right? These are all incidental nodules. And at this point in Fleischner, you'll see here that the magic number was about 4 millimeters. And if you had a 4 millimeter nodule or less, it did not have to be followed up in low risk patients, which is difficult to exactly what they mean by high risk or low risk, but essentially it's a significant smoking history or not. And you'll see here that as the nodules get bigger, you follow them closer and for longer times. And we'll go over this later on the updated Fleischner. So again, these only apply to incidental nodules that are found incidentally. It does not apply to patients with known malignancy. We talked about how common metastases are in the lung. Okay, this is the new updated Fleischner guidelines. And the most important things to know are that nodules now less than 6 millimeters, not 4, are considered benign in a low-risk patient. So whereas before, if you had a 5 millimeter nodule in any patient, essentially it needs to be followed in a year. That's what Fleischner would say. And the current guidelines are if it's 6 millimeters or less, it does not need to be followed in a low-risk patient. In high-risk patients, another new thing they say is optional. Before it was recommended at 12 months. Now it's optional. That's the words that we use, right? And as they get bigger, you follow them more closer. Actually, in this case, similar. Actually, the follow-up guidelines are very similar in lower high-risk patients with a single nodule. It gets more complicated with multiple nodules. But again, basically, you use the most suspicious nodule as the one that manages what happens to the patient next. Okay, so let's just go for a couple of more examples of this. So this is an issue of the exam way you do it. So thicker cuts, things, because you can cut at the edge of them, they can look less dense or ground glass in this case. But if you had a real thin slice, you would see that it's actually more solid. So in today's world, you can't really call things solid or non-solid without thin cuts, 1 millimeter slices, which we already discussed. So 6 is the new 4, and this change is based on this data that shows that there's such a small risk of malignancy even in patients at high risk. On the other hand, suspicious morphologies, upper location, or both can increase the cancer risk to the 1 to 5% chance, even at these small sides. So a follow-up in 12 months is recommended. So here's an example here of probably an 8 millimeter nodule on the left upper lobe. So, things, I'm not, I'm not going to really get into this from a radiologic perspective. And I've been doing this for 15 years. I probably read thousands and thousands of chest CTs. It's actually a lot more suspicious when you have one nodule and what looks like a clean set of lungs like this, as opposed to if you say a bunch of littler ones, a junkier set of lungs, they become less suspicious. But with one just like this in an upper lobe, it gets suspicious even at this small size. So 8 millimeters, this is very suspicious. And you could see that in whatever, I don't have the time frame here, but let's say in a year or 2 years, it grew significantly, right? And at this point, this is 100%, it's almost certainly a malignancy, primary lung malignancy. So again, I kind of talked about this, but multiple solid nodules are actually a little safer when we see them than a single one. And again, a 12-month optional follow-up is considered for patients deemed high risk. Okay, let's continue. So follow-up non-contrast chest CTs can be followed. So if you have new nodules, generally, let's say you're following somebody for whatever reason, somebody with a known cancer or somebody that you're looking at nodules or following nodules, and then you see new ones. Those typically tend to be inflammatory, and they can be followed up in short term because very often they'll go away. Once a nodule becomes 1 centimeter or bigger, and sometimes even smaller, you're not supposed to follow it anymore. We don't like to follow lung cancer. So the question becomes, what do you do? So once the nodule is of a sufficient size, then you can start talking about other tests. So outside of following it, now you could actually do a PET CT. You could take tissue either from a bronchoscopy or for percutaneous CT guided lung biopsy. Right, so bronchs are generally bigger. Well, these days, Tim Harkin and some of our other pulmonologists, they're excellent at getting these nodules, and they actually can use a CAT scan as a guidance for a virtual bronchoscopy, or sorry, actually a CT guided bronchoscopy, which Tim Harkin does. So central and larger lesions are easier from bronch, but they are becoming increasingly able to get them in the periphery. For lymph nodes, bronch is really the only way to go. For paratracheal higher lymph nodes, bronch is the best. CT-guided lung biopsy generally is better at the peripheral ones, but we can hit the ones that are more deep in the lung, and then there's surgical biopsy or excision. So just to go over some PETs, so what PET does. So it's a combination of the CT, that's the CT part, and the PET, which uses generally radioactive sugar. When the SUV, which is the standard uptake value, is greater than 2.5, which is what they report, is the uptake value. Generally, above 2.5 is considered malignant. And you can see in this case, this is a smoothly marginated mass or nodule. And you can see here that there's peripherally high intensity with low intensity in the center. So this is a necrotic nodule, and this was a sarcoma met. So I personally do not love PET for as a problem solver, because generally when we're dealing with a nodule, or let's say maybe an ill-defined consolidative or an ill-defined nodular density, if the differential is infection or inflammation versus cancer, the PET is really not going to be helpful, because you would anticipate all those etiologies to be active. If the differential was mucoid impaction or a chronic nodule versus malignancy, the PET could help, right? Because if it's cold, then you could rest assured a little better, and you don't necessarily need to think about going to tissue analysis at that point. But again, it doesn't really help you when the differential is something acute or cancer. So everything eats sugar. Almost everything eats sugar. Malignancies love sugar. Some classic malignancies do not pick up sugar, like a carcinoid. But again, how often can't stress how often these things are granulomas. And in the literature, if you take out a hyperactive nodule that's not cancer, it's almost always a granuloma. Generally, 1 centimeter is that number where the PET can be reliably used. And if it's less than a centimeter, people can say that the resolution is suboptimal for that small of a size, and you can't really accurately say whether or not this is picking up sugar or not. Okay, so CT-guided lung biopsies, this is a depiction of it. We do a lot here. Dr. Yankelevitz is one of the world leaders at this. He's able to hit very small nodules in the 5 millimeter range. Essentially, when you hit a nodule, you can either use an FNA, a fine needle aspirate, which is a smaller amount of tissue that you're going to get, or a core needle, which is a larger amount of tissue. It's very good at diagnosing malignancy. Now, this is a very important point. When something is malignant from a met or primary lung, it's really not hard to make the diagnosis because the cells are relatively easy to get, either from a fine needle aspirate or from a core. The problem is, though, when we are dealing with things that are not lung cancer. So for infections or other granulomas, it becomes very difficult for the pathologist or the cytologist to say with certainty that this is benign. And very often what you get, not in this case, but when you get, let's say, a smaller nodule or something that you're not thinking that this is cancer, what the pathology comes back is a lot of the time is non-diagnostic or unsatisfactory, which generally, or at least in some instances, does not mean that was the inadequate sample or the fault of the proceduralist. It means that no matter what you would get from the nodule, it just doesn't have enough cells to make a diagnosis from. And yeah, you have to remember that the cytologist or the pathologist, they're only getting a very small piece of this nodule. So if they don't, if they don't see cancer, it's a lot to say that this is a benign nodule, and they generally won't. So again, it's not a fault of the proceduralist if you get an unsatisfactory result sometimes in these non-cancerous biopsies. So generally 10 millimeters is the size that we can safely biopsy, but again, we've done very small ones. The pneumothorax rate is around 10%. You know, Roger Flores, who's one of our thoracic surgeons, he says that like it's a miracle that every time we do this biopsy, it doesn't cause a pneumothorax. Chest tube placement is less than 5%. And here you can see there's hemorrhage in the lung from the biopsy. All right, so let's go over a quick case. So an 85-year-old with a long smoking history, rule out PE. So this was the scout from the PE study, just to show you how hard it is to find the nodule on an x-ray. This is the nodule. It's sitting right on a vessel. It's literally impossible to find. On the CT, it's much easier to see, right? You see that it's got irregular margins. This is unbelievably suspicious in this emphysematous patient in the right upper lobe. On the PET, it's quite avid. This one I don't even think was biopsied because the pneumothorax rate was going to be very high, and it was resected, and it was an adenocarcinoma, which is the most common lung malignancy, primary lung malignancy in the lung these days. Here's another case. This might have been a World Trade Center patient. I put this here, but I think it was a fake indication. You know, I'll talk a little about the World Trade Center patients that we see. You know, we do routine x-rays on them every year or two. They're very difficult. You know, you basically can say with some certainty that there's nothing crazy going on in the lung, but we do see these ill-defined things every now and then. So here you can see there's this ill-defined nodule in the right mid-lung there, and here is the CT. So you have this irregular nodular density with some other kind of patchy nodules next to it. So now what do you do? All right. Do you follow it up in a month to see if it goes away? Do you check if the patient's sick or not? Do you give antibiotics and then follow it up? Should you do a PET? Should you get tissue? Should you get surgery? Consultation. So, you know, this is a young person. We have to be, you know, I would say kind of aggressive in a situation like this. But at the same time, realizing that very often these things can be benign. So one good thing about this case is you can see that there's satellite nodules, which actually implies generally that this is not cancer. Cancers don't like to grow next to each other. So I don't have a great answer for what to do next. I would probably say do a quick follow-up because, again, the PET-CT is not going to be very helpful if we think the differential is an infection versus cancer. So there's no correct answer. In my opinion, there's not really a perfect answer here. What happened was he was scheduled for a biopsy, and when he came back for the biopsy, 4 weeks later, it basically had shrunk down, no treatment. And this is unbelievably common in our chest CT world, where sometimes what they'll do is they'll schedule a biopsy like a month later, and you know, if it's gone, it's gone, and if it's there, they biopsy it. it's also uncommon. So in this sort of situation, if I were to call the referrer, call one of you guys and say, is the patient sick? Almost always the doctors would tell me the patient is completely fine, no symptoms. So it doesn't surprise me at all when people have this sort of in their lung and they don't know it. Nobody knows it. There are no symptoms. It doesn't surprise me at all. Okay, here's another case. This is a 32-year-old with chest pain. Okay, so this nodule is a little easier to see, even though this is a big blind spot on x-rays, which is the central part of the lung because the hilar vessels are approximately this size. This is much easier to detect here, but in the central lung, it's not as easy. So here it was on the CT. So again, you have this sort of smoothly nodulated nodule with this one little tag and then an adjacent nodule. So the decision was made to biopsy this. Here was the biopsy needle, and this turned out to be a cryptococcoma, which is not that common here. We do see it. It's, cryptococcus and histoplasmosis is super common in the middle part of the country. We don't see this very often, but that was the diagnosis. Okay, this one, I think the nodule is a little easier to see here in the right upper lobe, a very scary location. Here it is. Okay, so we have a 10 millimeter nodule in the right upper lobe. So at this point, again, where it's sort of a difficult decision, what do you do next? The best thing to have would be an old one, prior, right? And in fact, that could put to bed a lot of these nodules. That if you had a 5-year-old prior that looked like this would be safe to watch then. But at this point, we really don't know what this could be, and priors would be unbelievably helpful. So here we do have a 1-year prior CT, and it looks almost identical, or it does look identical. So that should give us some sort of safety in how we're thinking. But at the same time, it's in the right upper lobe. It's pretty big. I mean, it's a sizable nodule. It's 10 millimeters. And so the decision can be either to pet it, maybe because at this point it would be unlikely to be active if it was just a granuloma or an infection. Theoretically, continue to follow it, right, or potentially put a needle in it. So in this case, again, the decision was made to needle it, and it came back as non-diagnostic or unsaturated because it wasn't cancer. It was probably a granuloma. And unless you get that one granuloma in the biopsy, they're just going to say it's non-diagnostic. That's just what they do. It's very difficult for them to diagnose benigni from a single pass from an FNA. Okay, here's a case that's pretty old at this point, but we see here an 11 millimeter nodule that's smoothly marginated that over 2 years grew to 16 millimeters. So this is a slow-growing nodule, an atypical nodule for cancer. I mean, for metastases, but not crazy for a primary something in the lung. So it is growing, and the decision here was, you can see it better on the soft tissue windows. Here was the biopsy, and this turned out to be a carcinoid. So carcinoids, again, have a different appearance than primary lung cancers, which are almost always irregular and much uglier looking. Carcinoids tend to be very smooth, often endobronchial, but sometimes just in the lung, and this was a carcinoid. Okay, here is an x-ray for a patient who was feeling sick, and here we have a pretty sizable nodule in the left lower lobe, well circumscribed, smooth, and round. So here's what it looked like on the CAT scan that they use contrast for. And you can see it has this peripheral rim of enhancement and more central lucency. Its margins are intermediate, not particularly irregular, but not smooth either. So there's a wide differential here. Over time, I think this was followed in like a month later. We can see new air in the nodule. This would be very atypical for a lung cancer or any malignancy actually that hasn't been biopsied to develop air. So this looks like it's an evolving infection more than a cancer, and this was resected, and it turned out to be an abscess with necrotizing and non-necrotizing granulomas and no malignancy. It is what it is. Okay, next. Young patient for a renal stone CT. So this is an impossible thing just to remember sometimes that the lung can go under the diaphragm on a single view like this. And then here's a very common situation where you get a belly scan and you see a nodule in the lung. Now this is a big nodule. This is probably 20 millimeters or 2 centimeters, but it has very smooth borders. It's incidentally found. You'd be forced to really work this up in any person who can be worked up. What happened in this patient, I'm not sure exactly what happened, but nothing was treated. And in 2 months, it became this scar-looking thing. And then 5 years later, it became just a scar. So we see this all the time on CTs, where you see these irregular fiber nodule densities or very thin linear densities in the lung, and sort of the lung shows all of our battle scars through our life, and just like rings on a tree, you can see old infections and old problems that have healed in the lung. It shows its scars. Here's another case of a 35-year-old with a cough. Okay, so there's a nodule here. Here it is. Right? It's in the left lower lobe. Again, it's smoothly marginated in the lower lobes, less likely to be a primary lung cancer, but certainly within the spectrum of possibilities, it could absolutely be a lung cancer. If we could have one thing outside of pathology, the best thing would be an old study. So here in this case, we had a 3-year-old x-ray of the belly where you can see this in the left lower lobe. Right? So now we're thinking, okay, not going to be, probably not malignant. And then when we look at it closely with the CT, we can see that it's very heterogeneous. You have these low density areas, you have calcifications in it. It's got the so-called popcorn calcification, these speckled calcifications, and this is the most common benign entity in the lung, super common hamartoma, right, which is a benign growth in the lung that has lots of different cell types. So they're usually found incidentally, peak age and middle life. Here in this one, you can see there's fat. It's the most common, so 8% of all lung tumors in the lung are going to be hamartomas. It's the third most common cause of a solitary lung nodule. It has a bit of a male predominance, very often found in the peripheral part of the lung. Has at least 2 mesenchymal elements in it. Only a quarter have calcifications. The calcifications make it easiest to identify. The fat is sometimes difficult, and I don't think I have an MRI of this. No, I do. Okay, so some have no obvious fat or calcium, like this case. Again, it's in the lower lobe. It has some benignest features, but you can't clearly say it's a hamartoma because it doesn't have any other features to it. And we're getting better at doing this. MRI of the lung generally is not a common study performed. And the reason is that all of our MRIs are basing things on water. And the lung doesn't have water. Or has very minimal water, so it's not routinely used, but it can be used in a situation like this because MRI is really good to characterize the tissue. And what you do in this case is you can see here that there's some heterogeneity, there's some signal loss from internal fat in this nodule, and that's a hamartoma. Okay, here is a patient with a history of vulvar cancer. Maybe these are nodules or a nodule in the left lung. Here it was, right? It grew from this size, a couple of millimeters, to over a centimeter in a year. That's about a malignancy. That's a good growth rate for malignancy. If it was a MET, you might anticipate this to grow quicker, but this is only 4 months, so if the patient has a known malignancy, this is a very good look for a MET. There it is. It was biopsied, and this was a metastasis. Okay, another example of a patient with chest pain. So here we can see this nodule here in the right lower lobe. Now again, what you would want to see is an old x-ray. So here's the old x-ray from 2 years ago, and you don't see it there. So we CT'd it, and all it was a healed rib fracture. This was the nodule. And this is very common, where what we misinterpret on an x-ray is not a nodule, it's actually something else. So I'm going to quickly go over some of these. Here's another one. This is a very well-defined nodule. Now on the lateral, it's very difficult to see in the lungs itself, which you probably would expect to be able to see something this size on the lateral. But in fact, it's here. It's in the patient's skin, and we CT'd it. We didn't realize on the first x-ray, this was actually just a big skin tag, which gave that appearance of a nodule on the lung. So here are some other mimics, right? The nipples are big mimics. We can use nipple markers to differentiate them for true nodules, like this with nipple markers. Cutaneous nodules or warts, rib fractures we already talked about. Fluid or the pseudotumor in the minor fissure here is a mimic, right? On the lateral, it's very easy now to identify this as being a shadow of a fissural thickening or fluid, right? Artificial and then overlapping vascular markings or artifacts. These are all reasons to incorrectly diagnose a nodule on an x-ray. To talk about World Trade Center and lung nodules for a second, because this is very opportune for the group here. This is an actual paper from the 2020 in the Annals of American Thoracic Surgery, where they basically took World Trade Center responders, and they treated them like lung cancer screeners, and they graded them like a lung cancer screening CT. And what they found was, of these 1,600 patients, 60% at least had one nodule. Very common. This is probably around the number I would expect for regular humans that weren't exposed. Of the 1,600, 55% lung rads level 2 finding. I'm not going to go over the different stages of lung rads, but the higher they are, the more suspicious they become. 5% had lung rads 3-4, which is basically a very suspicious for malignancy. So a small group from the scans had something already suspicious. And basically one of the comments that were made from this data was that the presence of pulmonary nodules in this cohort is very similar to the lung cancer screening cohort, and that maybe people with this sort of occupational exposure should be screened like a lung cancer screening study, like a lung cancer screening patient. And honestly, the jury is out on something like this. This has to be studied more. I will say that these lung cancer CTs have an unbelievable, or these low-dose chest CTs in general have an unbelievably low risk to hurt the patient. So we talked about the radiation risk. And then another thing is that, why I would recommend having your studies read at an academic center as opposed to a private group in the community is that, the people who do this for a living, who just do chest or do their specialty and who can be part of multidisciplinary groups, we know best that most nodules are nothing. And so when we read them, we generally don't scare people into saying that this is cancer or scare the patient or cause unnecessary further testing. So I think it's a very safe test that you can do every year to some groups same patient groups that you may think are high risk, that you want to make sure they don't develop a lung cancer. And I would say, yeah, you should probably consider doing a routine chest CT, either every 1 year or maybe every 2 years. Again, there's no guidelines for this. Okay, so then just quickly going over some other nodule characteristics. They can cavitate. Generally, the thicker or irregular wall is more likely cancer. Smooth walls tend to be benign, like infectious or inflammatory etiologies. The ground glass halo is something very commonly described in fungal infections. Here we have this solid nodule with the surrounding ground glass, the so-called ground glass halo. This is very important. I think the chest community has become more confident in understanding this, which is that when you have a nodule on a fissure, it is not considered a pulmonary nodule. It's called a periphyseal nodule, and in almost always these cases, this is a lymph node in the lung. So currently, even for lung cancer screening CTs, these are not counted, and these are unbelievably common. So up to a third of all reported nodules are probably these fissural nodules, which don't count. But again, this is why you should get to know your radiologist, especially if you're sending a lot of chest CTs to some group. Generally, chest radiologists are much more knowledgeable about these entities. They can change in size, which gets a little scary for some people, but lymph nodes change in size. That's what they do. They don't require follow-up when they have these benign appearances, right? The problem is, and this is a very common problem in radiology, is that the most benign thing can also be malignant. And in this case, the difference is that these fissures are studded, so there are numerous, 10, 20 of these nodules. That would be atypical for lymph nodes, and which would be more compatible with pleural metastases. Okay, tree and bud is something that you'll hear a lot. So this is what it's representing, which is essentially the distal bronchioles as they branch, just like leaves on a tree. So this is the tree and bud, which is almost always a sign of small airways disease, usually of a bronchiolitis, so viral infections, mycobacterial infections. Those are typically the etiologies for when we see things like this. Okay, so then to go over the difference between non-solid and solid, this is very important and something that really is not intuitive. So instead of calling these ground glass nodules, we call them non-solid, and they're basically a new entity with the use of CT. Before this, you never saw these on X-rays, and even in the early beginning of CT, the sections were so much thicker, you infrequently see this. So a non-solid nodule is pure ground glass. A part solid nodule has a portion that's ground glass and a portion that's solid. These are very suspicious nodules. They're considered, when they're at these low stages, if you took them out, they'd be these etiologies called adenocarcinoma in situ or minimally invasive adenocarcinoma. And at this point, this would be 100% cure rate. The problem is that we can start entering the issue of overdiagnosis of lung cancer, which is when you resect something like this and it does come out to be an early lung cancer and you feel like we've saved somebody. Well, that's not really the case necessarily, because we don't really understand the natural history of these nodules, and this probably would never have killed the patient depending on the age. So that's really, they died from something else. So that's where the overdiagnosis of lung cancer comes into play. So here's the sort of recommendations when you're dealing with a ground glass or a part solid nodule. And they say here that these should be for until 5 years. I've seen plenty of lung cancers that look like this that really take off after 5 years. So in my opinion, if you're old enough to have a surgery or old enough to have treatment for a cancer, then they just continue to follow them for a year, every year, forever. Okay, so again, this should not be considered benign with 2 years stability. And as you can see here, that 3 years later in this case, so as opposed to most solid nodules that we can say with Fleischner that after they're stable for 2 years, you can consider them benign. That's not the case for a part solid nodule. Again, they recommend up to 5 years follow-up, I would say indefinite. And you can see here that the solid component has increased in size in this nodule, which is essentially an adenocarcinoma by definition when you see something like this change over time. And even Fleischner at this point would say this can just be resected. You don't have to biopsy because it's so unlikely to be anything else. PET-CT is of very little value when it's mostly ground glass, and that's because these tend to be indolent cancers at that stage, and they're not going to take up sugar. So you'll get a false negative from a PET. Well, it's not really a false negative. It's truly not neoplastic at this time, but it shouldn't mean that it's benign. Again, a lung cancer overdiagnosis we talked about, and the most likely malignant nodule is a part solid nodule, which is malignant 2/3 of the time. Right, so a nodule like this is going to be cancer 2/3 of the time. Okay, so these adenocarcinoma spectrum lesions, which is what we're describing, used to be termed these bronchoalveolar carcinomas, which is a term that's not used these days. Again, here the pathology, what the pathology would look like depending on the stage, and if the solid component is less than 5 millimeters, it would probably be a minimally invasive adenocarcinoma. We talked about the 100% cure rate. Okay, so then progression with time, just to see this one, this is a pretty much ground glass, not solid nodule in the right middle lobe at this point. In 3 years, it became solid in the middle, so this is very suspicious for an early invasive lung cancer. And then in 9 years from the original scan, you can see what happened. And this became incredibly more solid, more spiculated, and 100% lung cancer. One of the issues is that very often the patients have multiple. And these are the groups that tend to not be smokers, very often Asian women or just women who have these non-solid nodules or part solid nodules, like many of them all through the lungs. And this is a patient who has 1, 2, 3, 4, 5, 6. And generally what we'll do, and generally there are different stages of their evolution. And again, we don't really understand the natural history when this happens. But then what we believe the natural history is that they are non-solid and part solid and mostly solid. And what generally is done is you go after the most aggressive looking one. And this is where lung cancer or lung sparing surgeries are very helpful, because this patient is probably going to need a number of surgeries over their lifetime to take these cancers out. And another important thing to understand is that when you have most of these nodules, even with one aggressive one now, these are not Mets. It's very unlikely that even a lung cancer, known lung cancer, will metastasize within the lung itself. It can do lymphangitic carcinomatosis more frequently. It can spread to the nodes, but it's infrequent to spread to the lung. And also, these don't look like Mets. They're non-solid. Some of them can be irregular, and they're all primary lung cancers, each one. All separate primaries in this case. That one and this are separate primaries. They look like primary lung cancer. Okay, here's another case. This is what looks like a cavity, but this is in fact something called a pseudocavity in the setting of these adenocarcinoma spectrum lesions. And this is because of the lipidic growth, which means they grow slowly and they don't invade bronchi. They tether open the bronchi. And that creates this pseudocavity, and this can easily be distinguished as an early lung cancer based on that. All right, so 2 years prior, it looked very similar. Okay, this was biopsied and it came back atypical. Right? Already, this was suspicious to begin with. Now we have atypical clustered cells. This should be also suspicious for an early lung cancer. It was just watched, and 1 year later, it has grown, and it was resected, and it was an adenocarcinoma. Okay, so just a couple more cases here. So here we have a patient with two irregular nodules, one on the right apex, one on the left lower lobe. These both look irregular and ugly, and each one was needled, and they were both separate lung cancers, separate adenocarcinomas, not the same cancer, different ones. Cystic lung cancers are lung cancer that I think historically we've been not as familiar with, but now we're becoming much more familiar with. Whereas essentially you have these cystic air spaces in the lung that are usually the result of a prior infection or inflammation causing this cystic change, that over time you can start to see the walls become more irregular, more thick, right? And now it becomes more nodular here, and this is cancer. This is a cancer in an air-filled cystic space. This is what it used to be, and this is what it became. This was needled, and it came back lung cancer. Here are more examples of the same thing. This nodule over time, this cystic airspace over time having a more solid and larger nodule in the wall, and then eventually just obliterates the air-filled cystic space and it's just a big tumor. Here's another one. Right, so just for your knowledge that these things should be followed, especially with this sort of look with this ill-defined wall, and you can see over time this becomes cancer. All right, I think that's enough to stop for now. Thank you, and if there's any questions, I'll be happy to go over them.